Welcome to the Department of Medicine Grand Round Series. Today we are pleased to be joined by Dr. Mona Gupta and colleagues. Dr. Gupta is the interim medical director of palliative care at University Hospitals Cleveland Medical Center and an assistant professor of medicine at Case Western Reserve University. She served as faculty in geriatrics and palliative medicine at the Cleveland Clinic before joining University Hospitals. She is board certified in internal medicine, geriatrics, and palliative care. Dr. Gupta is the palliative care co-chair in the special interest groups within the American Geriatric Society, identifying and building on synergies that exist between geriatrics and palliative care. She serves on the Global Palliative Care Advisory Group, the American Academy of Hospice and Palliative Care, and the Steering Committee for Women Faculty School of Medicine. She has completed the Flex Leadership Program for Women Faculty at Case's School of Medicine. She was designated the most valuable person for the Chief of Staff at the Cleveland Clinic and has received multiple caregiver awards. She is very active in the community and serves in leadership roles with various nonprofit organizations. She is the palliative care co-chair for the Indo-American Cancer Association and president and co-chair for Research Showcase of the Association of Indian Physicians of Northern Ohio. She has been invited for various TV interviews on WJW Fox 8 TV, WEWS News Channel 5, Channel 19, and TV Asia. Please join me in welcoming Dr. Mona Gupta.
Thanks, Andrew, for that great introduction. I wasn't expecting that. Good afternoon, everybody. As he already pointed out, I'm Mona Gupta, one of the faculties in palliative care. And today we will be talking about we'll be discussing the different pain dimensions and how we can use these to arrive at a management strategy. How many of you know what do we mean by pain dimension or pain domains or total pain? What do we mean by that? If you have rotated in palliative care, I'm sure you should know, you must have heard the word total pain. Anybody? That's too bad. We didn't do a good job. Okay. So pain is the most common and distressing symptom in palliative cancer patients. Despite the fact that pain can be controlled, poor pain relief remains a challenge. Dr. Cicely Saunders coined the term total pain to address the multidimensional nature of pain experience, that is physical, psychological, social, and spiritual pain. That is why we have, we will be doing this presentation as an interactive panel discussion, and we have specialists from all different specialties here. Dr. Jenny Savoca, she's a faculty in palliative care. Wayne Brass, he's a spiritual care chaplain. He's in spiritual care in palliative care, chaplain in palliative care, and Josh Ohlinger, he is a physical therapist, and Kathy Jo Gutzel, she's a music therapist, and Barbara is art therapist. Thank you everybody for joining. So this talk is divided into 3 parts. First, we will discuss the holistic care model. Second part will be focused on how we can use this model, this holistic care models, in discussing the different dimensions of pain. And third is management strategies of total pain. Pain is whatever the experiencing person says it is, existing wherever he or she says it is, and pain is a symptom, not a diagnosis, and we have to believe the patient. Fear and depression are a part of life. In illness, there are no negative emotions, only experiences that have to be lived through. What is needed in these moments is not denial, but recognition. The ill person's suffering should be affirmed, whether or not it can be treated. What I wanted when I was most ill was the response, yes. We see your pain, we accept your fear. Describing pain only in terms of its intensity is like describing music only in terms of its loudness. So we'll walk through this case of Mrs. ID, to illustrate that optimal pain relief is not possible without addressing all the dimensions of total pain. She's a 55-year-old female with recurrent anal cancer diagnosed in March of 2017, received chemo and radiation, which was completed in June 2017, and had surgery with colostomy again in the same year, and has had multiple post-operative complications requiring additional surgeries. She was admitted in May 2018 with worsening pain and found to have recurrent cancer and underwent radiation of the pelvis. And at that time, palliative care was consulted. And nivolumab was started in August. But the restaging scans soon after starting the nivolumab showed that she has widespread disease with mets to lung, liver, bone, and bladder invasion. This time she came with increasing weakness, pain, and decreased PO intake and was admitted in September, just this month, for IV fluid and IV med support, and palliative care was again consulted. On examination, she is laying in bed in a lithotomy position due to pain. So what other information do you need regarding her pain? Anybody besides what we have just discussed or told you? Okay, yes. Quality of pain. So basically physical assessment, that will come in physical assessment of the pain. What else? Okay, yes, physical pain, yep. Anything? Anybody else? Pain assessment. I haven't given you any information. Yes, prior pain regimen, yes.
Is there pain, any some problem for patients or gas management, which is very, very important?
Okay, great. How it affects the functional status and daily living, yes. Severity, yes.
Where is the pain?
In pelvic area. So I'm hearing all the physical assessment portion. Anything else you want to know about this patient which may be affecting her pain? Okay, psychological issues, any which may affect her pain, yes. Excellent. Support at home, social, excellent. Psychological, social issues which may affect her pain. Economic, social issues, again, social issues. So we've had physical, psychological, social issues. There's just one missing. We'll discuss that. So the topic, this topic is divided into three parts. First, we will discuss the holistic model of care. And the second part is focused on how we can use this holistic model in discussing different dimensions of pain. And third part on management strategies of total pain. So let's discuss the holistic care model. I'm going to show you a video, just a 1.5-minute video by Dr. Cicely Saunders.
Pain. I think that those two old myths of drug dependence and tolerance have still not really been dealt with, in spite of all the proofs that we now have, the studies that have been made, they haven't got across. And I think a major reason is because medical students in a teaching hospital largely see acute pain, post-operative, post-trauma, post-burn, whatever. And acute pain is an event, and it's got a built-in meaning. But, of course, patients dying of cancer and other diseases as well have a chronic pain, a continual pain. And to treat it as if it's an acute event, when it's really a situation in which the patient is held, is completely illogical. You need to give your drugs regularly. You need to give them balanced to the patient. There's no standard dose. And you need to be alert to the whole person who has the sort of total pain that I recognized when I started in St. Joseph's. and described back in the early 60s as total pain, with its physical, psychological, social, and spiritual components, a whole experience for the patient.
I'd like to talk a little bit about the historical significance of the Cicely Saunders archive, and that for me really is a story of how it's come to reach the...
So that essentially is holistic model of care and total pain. So what are the domains of holistic care? Physical, psychological, social or cultural, and spiritual. Well, doctor, the pain begins in my back, and now it seems that all of me is wrong. So what are the different aspects? In physical pain, you can have any diseases, pain and other symptoms, function, or in physical activity. Psychological could be emotions, coping responses, loss and grief. Social or cultural, as somebody pointed out, finances, economic situation, relationships, legal issues, family or caregiver support, and spiritual issues, what brings meaning to their life and their values, existential issues, and any losses and griefs they've had. At one point of time, patient may have more of physical issues going on with them, and rest other issues may be minimal. At other point in time, they may have more psychological experiences affecting their disease or affecting them, and less of other issues. And similarly, more of social or cultural issues at one particular time. If they're undergoing some economic burden, then that is the most prominent issue which they're facing. Rest is minor issue at that point in their life. And similarly, spiritual issues may be more prominent at one point of time. So this, we just discussed physical, psychosocial, spiritual issues, and they are affected by the environment we live in, the community we live in, your family, friends, whether they're supportive or not supportive, and the care setting, whether you're in the hospital or home or nursing facility. And this also is affected by the interprofessional relationships, how we as healthcare providers communicate with each other and arrive at a management strategy for a patient. And above all, society and culture as a whole, where we live in. Every culture has, every society, people where they live in, they have their own cultural beliefs. So we just discussed the holistic model of care, the first part of the talk. Now we will see how we can use this holistic model of care in discussing different dimensions of pain. So now the dimensions of total pain. We discussed, this is physical pain. What will you do? You do a comprehensive pain assessment. I heard people saying quality of pain, severity. That's all physical assessment. Then psychological assessment is fear, anxiety, anguish. Social, family and friends supportive or not. Whether the patients sometimes have a feeling of being burdened on their family. And spiritual assessment. Spiritual pain, which needs spiritual assessment. So this is again, total pain, physical pain, patient because of debility or side effects of the therapy, chemotherapy, radiation, surgery, and some non-cancer pathology, for example, hemorrhoids or bunions, and then cancer itself can be pressing on nerves or organs causing pain. And then this is the psychosocial pain because of therapeutic failures or delays in diagnosis or therapy. Patient may be worried about family and loss of dignity, and sadness because of disfigurement, and then spiritual issues. So I'm going to have Jenny is going to talk about some physical pain assessment.
you. A couple words about pain assessment, since as a palliative provider, this is something that I deal with a lot, and some things that I have found helpful. So the goal of a pain assessment is to get a really thorough description of pain, and the reason is that pain is a symptom and not a diagnosis, and you can often use the history to figure out more specifically what is the etiology of the pain, and that allows you to provide a more targeted intervention. We have numeric rating scales. Not every patient can use these in a meaningful way. A patient who tells you their pain is 12 out of 10 every time you meet them, that's not helpful, but the majority of patients can. But I find it helpful for myself to ask them, what is their pain now? What is the worst that it's been in the last, and you can pick a period, a day, a week. What's the best it's been? And what would be a tolerable level of pain? Because I try to explain to people up front, like, I could probably get you to 0 out of 10, but it might require general anesthesia. So what can you live with? And I find that setting expectations early is helpful. For patients that can't meaningfully participate in the 1 to 10 scale, there's something called the functional pain scale that I use, which I find to be helpful. There's only one question that you ask the person. Is this tolerable or intolerable? And then you use behaviors to figure out what their score is. So if they tell you that their pain is tolerable, but it prevents them from doing activities, for example, that's going to be a 2 out of 5. If their pain is intolerable, but they're able to do whatever it is that they would like, watch TV and read a book, visit with family, that's going to get you a 3. It's a 5-point scale. 5 is the patient who has intolerable pain and can't even talk due to their pain. They maybe are sitting there rocking. And I had a patient once who gave me a 12 out of 10 every time I saw her, but using the functional pain scale, we were able to get her from 5 to 4 to 3, and then eventually it's just 2, despite the fact she's still telling me 12 out of 10. And then for patients that can't really provide a history, there's a variety of nonverbal indicators that I use, which would include facial expressions like a grimace or a brow furrow, vocalizations, meaning like moans or groans, restlessness, so somebody who's constantly shifting in their chair trying to find a comfortable position, or maybe rocking. And body positioning, what I'm referring to, is somebody who's bracing, like maybe holding an area of pain, or rubbing, or sometimes holding themselves in a very rigid position to prevent any movement. And then the pain signature is something that is a patient-specific pattern of behavior. So this can be especially helpful for patients that can't report. You ask their family or people that know them, and they'll say, gosh, every time Dad does this, that means he's in pain, or something like that. That's things maybe you wouldn't know about this person, but their family does. And then questions that I think can be helpful would be, what have you tried that has helped? Sometimes you'll have a patient who really just wants a hot water bottle to put on their stomach, and we have hot packs that you could give them. What do you think is causing the pain? Sometimes patients have really good insight and can give you really good history for that. And then, do you have any worries about the pain? Gets to this question about total pain that we're asking. How is it that they are interpreting the sensations? Because the thing about pain is that it's subjective. We don't have a way to measure it. There's not like an EKG that can measure the number of nociceptors that are firing at one time. I'm not sure that would be helpful if we did have it, though, because, if you go forward one. Yeah, so, and then one more. So this is an optical illusion that shows that, a line that's the same size appears different. Like, hopefully it is projecting that way. The top one looks longer than the bottom one because of the arrowheads. So the way that you're looking at something can affect how how you're interpreting it. Pain is not a brain input. Nociceptors give you the input. Pain is the output. And so it's the interpretation of the sensations that you're having.
So we'll walk through this case of Mrs. ID and see what physical pain she had. She had a pelvic pain and pressure, severe pain of 8 out of 10. This was a visceral pain. Shooting down right leg, neuropathic pain. You need to do something. I can't keep doing like this. She's on methadone 30, 25, and 30. Dilaudid 4 to 6 milligrams every 3 hours for breakthrough pain at home. Morphine 5 milligrams every 3 hours for pain in the hospital, PRN. But she still feels it might be too small of a dose, and it isn't doing anything. She's also on gabapentin, duloxetine, and lidoderm locally. These are the factors that can affect the pain threshold. What can lower the threshold is you have more pain, is discomfort, insomnia, fatigue, anxiety, fear, anger, sadness, depression, boredom, mental isolation, and social abandonment. That is psychological and social pain. And then the ones where the threshold is raised, that is you have less pain, and there is relief of other symptoms, sleep, sympathy, relaxation, elevation of mood, analgesics. So this is the psychological or social pain. So in Mrs. ID, she was anxious, depressed, especially when she's alone at home. On examination, she has some eye contact, but she's withdrawn, blank stare, very slow to respond to greeting or asking about pain, not responding when asked about pain, and psychomotor retardation in both speech and motor activity. Social issues, she has a very strong social support. Family's always there with her when she's at home. She lives with her husband and sister, and she had 2 adult sons, and a 35-year-old son committed suicide during her stay in the hospital in May. So she's worried what happens when she's home alone. The end result is what concerns me. She's concerned that she's a burden. So spiritual pain. She hadn't opened up with any of her providers during her May admission. With this admission, she opened up with one of our providers, and she stated that she's fearful that family will not be able to handle the emotions of what will happen, meaning her death. She's uncertain whether the issue was dying at home or simply the act of dying. And she's unsure whether her fears are more about her family's coping or her own fears. So when I'm assessing these patients, I question myself, what am I learning about myself when I listen to someone who's suffering? And how can I truly be present to someone who's suffering? Present in the moment. So as I said, this talk is divided into 3 parts. One was holistic model of care, and other was discussing different dimensions of pain. So we've discussed those 2 parts. Now we will discuss the management strategies of total pain. So you've seen this figure before. When the patient has primarily physical pain, you do a comprehensive pain assessment. And it's more of a psychological pain that could be because of fear, anxiety, or anguish. And social, as we said, effects on family and spiritual needs. So for physical pain, everybody knows WHO ladder for management of pain. For psychological, complementary therapies, some pharmacological therapies, dignity-conserving care. And for social issues, what are the family dynamics? Is the family involved in their care or involving the family? Because sometimes with her concerns, the concerns she had, if we have a family meeting with her husband and the sister addressing her concerns, that probably would relieve some of her anxiety about going home. And then, spiritual assessment, which we'll talk about more later. So again, we'll turn back to our panelists to discuss all these different aspects and how we can manage. So we'll start with the physical assessment, and then Jenny's going to talk to you about the management of physical aspect of pain. Before that, I just mentioned about WHO ladder. I don't need to go into detail. You all know. Step 1 is starting with simple analgesics and NSAIDs. And then if the pain is not controlled with that, weak opioids and NSAID, and if it's not controlled, then you go to stronger opioids. And remember to give the medications by the clock, by the mouth, and for the individual. Jenny.
Okay, I don't want to take too much time because I want to get to the rest of our panel. And so I just threw up a couple of things that are like the important principles when addressing pain with opioids. And I'll just highlight a couple of them. So for patients who are having constant pain, and not just pain that's incidentally or occasional, we would recommend around-the-clock dosing of pain meds. This is somebody maybe with a scheduled medication rather than just a PRN-only strategy. For a patient that comes in a pain crisis and was on pain medicine at home, we know that whatever they were on was inadequate, but we don't really know what it's going to take to get them under control. And for appropriate patients, I think PCAs can be really helpful. Better? Sorry. So for appropriate patients, I think PCAs can be very helpful for rapidly figuring out what it's going to take to get their pain under control. And then things that I look for on physical exam that can give you a sense of how, if there's any toxicities of opioids, things that show up before somebody gets sedated or before somebody gets respiratory depression would be myoclonus, decreased pupil size, and the respiratory rate. Okay. And then, the sort of big picture stuff, when we're looking at pain, we want to maximize non-pharmacologic interventions and non-opioid adjuvants. So, rice therapy. I think these are things that you would do for yourself at home. Sometimes we forget when patients come to the hospital, but they still work. So sometimes just ice is actually really helpful. Non-opioid adjuvants, all of the other meds that we use for pain, the TCAs or SNRIs or antiepileptics that we use for that reason. You want to make sure that you think about integrative as well as interventional modalities, and we're going to talk more about the integrative stuff, but interventional, like regional anesthesia, for example, for some patients can be really helpful and decrease their opioid requirements. And pseudo-addiction is something that can happen for patients who have uncontrolled or undertreated pain, where they're watching the clock and they're requesting their drugs every time. Maybe they know a drug by name because they've been admitted a lot. So sometimes it can be hard to tease apart which patients really have pain that's just undertreated versus who has an addiction issue.
And Mrs. ID, the physical pain management-wise, she was started on dilaudid PCA. She was using about 13 to 20 milligrams of IV dilaudid over 24-hour period, so the pump was increased, the dose of the pump was increased. Methadone increased to 30 milligrams TID, gabapentin was increased, and pain management was consulted, and she's being right now considered for either pain pump or potential nerve block. So another aspect of physical management is physical therapy. We'll have Josh talk about physical therapy in pain management.
Okay, so With pain management, the big focus now is, what you can do non-opiates, and physical therapy is emerging as one of the things, especially on an outpatient standpoint. In that setting, we can more directly affect the mechanism of pain. However, in this patient population, we can't really affect the mechanism of pain because that's the disease process. So when we assess these patients, we'll look at the physical aspect, where's your pain at, what level, but we're also going to look at what's their social situation, what's their function, try to tease out what are some goals for these patients, because usually they're losing their ability to be independent, and that starts to cause more depression, more issues that kind of then just makes their pain appear worse. So with this patient, she had been admitted back in May and then in September. When we saw her in May, I think we were able to get her to participate with us maybe once or twice because she was refusing for pain. This time, she actually let us get more involved with her. And the nice part this time around is she went from being in bed, non-mobile. She couldn't do anything for herself, wasn't really getting up. She was now getting up to a chair. She was walking in a room. Just the other day, we actually had her walking in the hallway. The great part to that, especially the psychological aspect of this patient's care, the fact that she's up in a chair means that she can engage her family, those people that are there with her, which takes her focus off of the pain. When she's laying in bed, all she would think about was her pain. So the fact that she's up and she's eye level, especially even when practitioners come in, that allows her to be more involved with her care and to start to focus on things other than her pain. The other thing with pain, sometimes therapy can help modulate pain. So the pain is obviously a big part of his interpretation in the brain. And when you have a painful region, if it's painful over a period of time, the brain starts to misinterpret typical mechanoreceptors, typical signals. Something that might be dull, it suddenly feels sharp. If you start to get that part of the body moving again, start to get feedback to the mechanoreceptors, you can start to desensitize that part of the body. So they stop misinterpreting the pain as much, and they realize, oh, wait, I can actually move that limb. Her right leg, I think it was the right leg, was very painful. She realized, oh, I can bear weight on this leg. I can walk on this leg. It hurts, but it'll still support me. But on that previous admit in May, she was adamant that she couldn't support weight on that leg and walk. So that's a big part of physical therapy. And I know we've gone as far as, especially some of these patients who are more at the end stage of their diseases, we've even been able to work with simple goals. I want to get up into a wheelchair so I can go outside. And we've made that happen for several patients where in their last few days we were actually able to get them into a wheelchair and get them outside, which gave them such like a positive experience. It gave them some dignity in their last days. So, and so just focusing on those things, focusing on small gains that we can make with the patient is a big part of physical therapy. So, engage physical therapy in the care of these patients. We won't directly affect their pain. If they have metastatic disease of the spine, well, we're not going to probably be very effective in decreasing their back pain, but we can make them more functional, and we can help with those other psychological and social aspects of their pain. So.
Interesting. Thank you, Josh. So next time, remember, always order physical therapy. So Mrs. ID, back to her. Her psychosocial pain management, we consulted psychiatry. They started her on Regimen in addition to Cymbalta. And then music therapy and art therapy played a major role in her management of pain. Especially, her pain seemed to be unresponsive to not only opiates, but any medications. We had tried her on all the other opiates, and still her pain was uncontrolled. That's when we switched her to methadone. But still, she had a lot of pain. And as you can see, which I told you briefly in her history, that she has a lot of other psychosocial, spiritual issues, especially when she's in the hospital. Her son died. This was during May admission. Her pain was totally out of control at that point. So, Kathy, can you please tell us something about the music therapy and how music therapy helped her?
I'm Kathy Joe. I want you to know that the music therapy in palliative care patients is evidence-based, and I have a couple of things for you to look at there. A study that was actually done in this hospital, I was the principal investigator in 2013, and it's published in the Journal of Pain and Symptom Management, had statistical significance of the music therapy intervention lowering pain. And then I referenced another study by Lisa Gallagher at the Cleveland Clinic. So we are evidence-based. So I want to talk about the 11 sessions in the May admission of Mrs. ID. Actually, I was only present in one of those sessions, but I'm going to report on the other sessions that were led by our wonderful music therapy intern, Judy Rubin. So I want to answer the questions, how did Mrs. ID manifest her total pain? I want to point out that that Judy asked her what were her coping mechanisms, and she said that her Catholic faith was a big source of strength for her. She's also a Latina woman, and she's a postal worker, so I just want you to know those things about her. So how did she manifest total pain? She declined Judy Rubin on the first 3 attempts. She was totally closed off. And then she finally did let her come in. She was unable to deal with and talk about the loss of her son while her own health was bad. She was able to compartmentalize this and say that she wanted to do her grieving and her processing once she got home. She said this often to Judy. How did Judy and music therapy treat Mrs. ID's total pain? Judy gave her some control over song choice. Initially, Mrs. ID chose songs about her faith. And then later, she chose songs about loss. But she would only choose the songs she would not process the loss. A song that she consistently went to is Hero by Enrique Iglesias. Does anybody know that song? Okay. I'm glad. So she wanted Judy to sing the chorus in Spanish, her native language. And the chorus is, I can be your hero, baby. I can kiss away the pain. I will stand by you forever. You can take my breath away. So she wanted this at the end of every session, and she even wanted it while she was having a bowel movement. And yet you can imagine with her diagnosis, that would be extremely painful to go to the bathroom. But she wanted Judy not to leave the room, but she wanted Judy to stay there and sing to her while she was going to the bathroom. I find that very tender to think about. So Judy felt that she was dealing with issues of healing and issues of a relationship with her son in this particular song, Hero. Was music therapy effective? After the 11 sessions, she seemed to Judy like a different person. She was warm. She hugged Judy. She was interested in others. Her pain numbers did not change, but her affect did. So how do we know that it was effective? By her affect, her manner, and the fact that she talked more in sessions every time as time went on. Although not about the loss of her son. She was consistent on that she wanted to process it at home. I was present, as I said, in one session, and Mrs. ID asked me to choose a song. And I chose Nada Te Turbe because she had told us that her Catholic faith was important. And Nada Te Turbe was written by St. Teresa of Avila, who is a Spanish mystic from the 16th century. And the translation is, let nothing trouble you, let nothing frighten you. He who loves God needs nothing. Everything passes by. God does not change. Only God is enough. And I'd like to sing it for you.
And I find it interesting when Kathy says that her pain was 5 out of 10. She stated it's 5 out of 10, but pain was, you could see that her pain is better controlled. So that actually tells us that she has more of psychosocial and spiritual pain than physical pain. This is only part of what Kathy does. She does a lot more than this. So next time, remember music therapy for your patients. And now, Barb, please talk about, how did art therapy help her?
So art therapy is a mental health profession that uses both the creative process of art making and psychotherapy to improve and enhance the physical, mental, emotional, and well-being of individuals of all ages. Many people think it's just for children. I only work with the adults at Seidman. This is the only image and the only time that I actually did art making with the patient ID, and this was very recent because she had refused in the past and in the previous admission. A couple of weeks ago, I connected with ID and her family, went into the room, had conversation. She wasn't up for doing anything that day, but I told her with what we talked about, we would continue the next session. I often ask patients where they get their inspiration from, what has meaning for them, because I think meaning making is key when you're working with people in palliative care. What had meaning for her that day was love and family. So I came back the next time, about a week later, and asked her to choose what she wanted to do, gave her choices. She chose to create something with wood, with the words love and family. And we did what we call the third hand in art therapy. If a patient isn't either up for doing something emotionally or physically, they direct us and guide us throughout the process, and we actually do the art making for them, but it's as if they were the conductor. So she told me what words, what colors, where she wanted everything placed, and if I didn't do it right, she let me know that too. So she was very particular about what she wanted to do and how she wanted to put it together. And this is what she did, and she gave me permission to share it with you. She also wants it glossed, which we will do hopefully today. What does art therapy do for ID? It eases some of her emotional suffering. It gives her a sense of autonomy when she doesn't have much. She could even kick me out of the room, which she did several times, and she's allowed to kick me out of the room. It gave her a little bit of confidence. It also brightened her affect. She smiled a couple of times, and I noticed she also has a very sarcastic side to her with some of the staff as well. So she does have a sense of humor that sneaks out every now and then. It also gave her a chance to strengthen her ego during a time when she's very vulnerable to everything and everybody. And also communication. A picture speaks 1,000 words, and I think this says what she's thinking and feeling, too, and can share it later with her family. Art therapy, as well as music therapy and other therapies, can take someone from being passive to having an active level of participation. Art therapy allows the patient to assert their identity to the very end of their lives. And could you advance the slide? This was a different fellow who had laryngeal cancer and then metastasized to the lungs. He was an artist in his previous life before he became the patient, but you don't have to be an artist to participate in art therapy. We used art to help him cope and adjust to his new diagnosis, and also for him to learn how to express his feelings. There were times when he wasn't able to speak. If you could go to the next slide. And one day in his outpatient chemotherapy session, he drew this and said this was his worst day. But he wasn't able to tell anybody that. He always wanted to have a smile on his face. Then later on, he did lots of things, but I just want to show you what happened later. He was the only patient to have a solo art show in the hospital, in the gallery, and it was featured on the cover of the Plain Dealer in 2015. And he went from this being the worst day of his life to this being the best day of his life. And they even quote him in the article saying, even the bigwig came by, meaning Mr. Zenti, to congratulate him. So he was able to use the art to help him throughout his treatment, and he was treated here for probably close to 5 years before he passed away. Go to the next slide. Art therapy can also help people when they find out their prognosis is poor and they're not sure how long their life will be extended, to reducing anxiety, and we use a lot of relaxation interventions to help them deal with that. And some relate to mindfulness, which I'll describe in a minute. This was done with a couple shortly before the patient, the woman, passed away. She and her husband traced each other's hands and then wrote sentiments about each other and then started playing with the watercolors, laughing, having fun, and writing again the sentiments about each other. And they were able to do something fun and creative together before she passed away. And we'll just skip, because I don't want. And then legacy work, I'll end with that. We use art to create legacy work, permanent artwork that family members will have, things that they want to say to family members that they want them to remember them by. That's a tile with a handprint that is fired in the kiln, and then using quotes and transparencies over a watercolor is the bottom one, where someone can choose a significant, meaningful quote and then doing a watercolor to go with it. So that's for that part. And then she wanted me to talk about mindfulness for a minute. Mindfulness is paying attention to the present moment on purpose and without judgment. Art therapy, I think, and music therapy are a form of mindfulness. We take patients into an active present moment, and we try to get them to get away from their pain and observe their thoughts and feelings and not judging them. And that's exactly what mindfulness does as well. And then sometimes we teach them breathing and meditation interventions also.
And I liked what Barb said, giving patients some control. Since they don't have any control over what's happening with their body, the cancer, but giving them some control is very helpful, and it helps manage their pain. So for Mrs. ID, social and cultural pain management, in the family meeting, she said that she wants to focus on quality of life, but also wants to continue the treatment. So I think what is needed based on what we heard, her fears about going home, being alone, burden on the family. If we have a family meeting with the husband and the sister, and in their presence, and if they can address some of her concerns, which she has, hearing it directly from them actually will be very helpful for her. And then there are cultural issues. Every patient has their own cultures, and just assess patients' beliefs and see if they can be helpful in managing the pain. So spiritual pain assessment and management in Mrs. ID. We have a specialist, Wayne. He can talk about what happened with that patient. How did he assess her?
My name is Wayne. I'm the chaplain with the palliative care team. And my relationship with ID was started off, I think, like some of the others, in that when she was here this summer, initially I would have conversations with family members, but they were saying she had too much pain at that time to have another person come in. And so I think she was here for about 3 weeks before I finally met her. And our interactions have taken kind of a formulaic pattern, in that, as you've heard, she is of the Catholic faith, and I work as a chaplain with all faiths or no faith, and I offered to her to have the Catholic priest come by. She said, "No, you'll do. You're fine." And so we've established our relationship, and it follows this pattern pretty consistently, in that we'll talk about what's been going on, although she has never gotten into serious discussion about the loss of her son with me either. But other family issues and memories of family experiences, she's full of stories about those. And at times her sister is present, sister who is very supportive of her in many ways, including spiritually. They have a practice whereby the sister, who's here most days, will, at the time that ID is getting ready for the evening, they will read scripture together. Their sister will read to her, and then they'll pray, and that's their daily pattern. The pattern that she and I have established is that we will talk for perhaps 20 minutes, depending on her capacity, her physical capability on a particular day, and then we'll pray together. And my approach with the prayer is to incorporate those things that have been shared in our conversation and offer them to God on her behalf. And that's kind of the pattern that we've developed. Oftentimes, experiences she's had with music therapy or art therapy are also brought into the conversation. She has a very very grateful attitude toward the work that's been done by you and your team. So I think that's basically our relationship. I think a person who is diagnosed with cancer, which is difficult to cure, becomes a chronic issue. The person with that diagnosis experiences a number of things that contribute to the total pain, and the heightened awareness of death. It becomes real. There's a sense of beginning to think about a loss of relationships that this person values. There's a sense of I am less than I was before, a loss of self. What is my purpose? If I had a purpose that I was clear about, how is that affected? And as has been mentioned by others, is the sense of a loss of control. Finally, a total loss of control, something that you're looking at as a patient in this situation. Thank you.
Thank you. So to conclude, holistic model of care should be used to address different dimensions of total pain. That is physical, psychological, social, and spiritual. And management requires an interdisciplinary approach. So please remember, just if you're managing a patient's pain by medication that's not getting control, there's something else you need to do. The patient doesn't have physical pain because it's not responding to the medication. Palliative care, what's the matter and what matters? This is Jenny's slide. So you want to speak something on this? This is just to show.
The description I heard recently, those are two things that we have to address.
Thank you. These are some resources and references for you, and thank you very much. Our email addresses in case if you have any questions, and any questions now, we are happy to take them.
Thank you to the whole panel for coming, and thank you for all the therapies that you do for our patients.